Today's topic is restorative dentistry for pediatric patients, focusing on various aspects such as methods to detect and diagnose dental caries in primary teeth, the restoration of primary teeth, and advanced restorative procedures. This video presentation is divided into 3 parts. In this first part, we will do the detection and diagnosis of dental caries in primary teeth, including discussing the latest advancements in this area. The restoration of primary teeth will be covered in 2 subsequent parts of the presentation, while advanced restorative procedures will be explored in the third part. Methods to detect and diagnose of dental caries in primary teeth. Diagnosing caries, particularly occlusal caries where cavities may not be overtly visible, presents challenges for dental professionals. To overcome these challenges and ensure accurate diagnosis, various methods and combinations thereof have been proposed. Here's a breakdown of some commonly used diagnostic techniques. Visual inspection. Visual examination of tooth surfaces under good lighting conditions remains a fundamental method for caries detection. Dental professionals inspect dry tooth surfaces for any signs of demineralization, discoloration, or enamel defects. Probe/explorer. The use of a dental probe or explorer aids in removing debris and plaque, facilitating better visualization of tooth surfaces. It can help identify areas of softness or irregularities that may indicate caries. Bitewing radiographs. Bitewing radiographs are indispensable for detecting caries, cavities between teeth, and estimating the extent of the lesion. They provide valuable insight into areas not easily visible during visual inspection. Electronic methods. Various electronic devices, such as caries detection devices, use different techniques like electrical resistance or impedance to assess tooth integrity and detect carious lesions. These methods can enhance diagnostic accuracy, especially in early-stage caries detection. Fiber-optic transillumination. This technique involves shining a light through the tooth, which allows for visualization of internal tooth structures. It can aid in identifying subsurface lesions, including occlusal caries, that may not be visible with traditional methods. Laser diagnosis. Laser devices emit light at specific wavelengths to detect changes in tooth structure indicative of caries. Laser diagnosis offers precise detection and can differentiate between healthy and carious tissues with high accuracy. Key point: combining 2 or more diagnostic methods significantly enhances the accuracy and detection rates of caries. For example, integrating visual inspection with bitewing radiographs or using electronic methods alongside fiber-optic transillumination can provide a comprehensive assessment of a patient's dental health. By leveraging multiple diagnostic tools, dental professionals can identify carious lesions at various stages of development and tailor treatment plans accordingly, leading to improved patient outcomes and long-term oral health. Equipment and examination. Basic equipment. Adequate lighting. Proper lighting ensures clear visibility during examination, aiding in the detection of carious lesions and other dental abnormalities. Compressed air. Air drying helps in removing moisture from the tooth surface, allowing for better visualization of lesions. Dental mirror. Mirrors enable the dental practitioner to view tooth surfaces that are not easily accessible, such as the lingual surfaces of anterior teeth. Blunt/ball-ended probe. A probe with a rounded tip is used to detect surface irregularities and soft spots indicative of carious lesions. Probe considerations. Avoid sharp probes. Sharp probes are contraindicated due to several reasons. Lack of diagnostic improvement. Sharp probes may not provide additional diagnostic information compared to blunt probes. Potential enamel matrix damage. Sharp probes can cause microtrauma to the enamel matrix, leading to potential enamel damage. Risk of bacterial transfer. Sharp probes pose a risk of transferring cariogenic bacteria from one tooth to another, potentially contributing to the spread of dental caries. Teeth preparation for examination. Drying. Drying the teeth is essential for identifying early lesions, as moisture can obscure visual examination finds. Flossing and temporary separation. Flossing and temporary separation aids allow for direct visualization of proximal areas, facilitating the detection of hidden carious lesions. Utilization of bitewing radiographs. Essential for hidden caries, bitewing radiographs are indispensable for detecting hidden caries that may be visible clinically, especially in the interproximal areas. Benefits. Bitewing radiographs provide valuable information for estimating lesion extent, monitoring lesion progression, and guiding treatment planning. Diagnosis considerations. Determining demineralization presence. The operator must the presence of demineralization and evaluate lesion depth and activity rate. Quantitative assessment methods. Techniques such as electrical conductance and laser fluorescence provide quantitative data that can aid in assessing lesion progression and determining the need for intervention. First visible sign, white spot lesions. Appearance. The first visible sign of dental caries is often the white spot lesion. Initially, it is observed when the tooth surface is dry because demineralized enamel becomes porous, creating a white appearance. As caries progresses, the lesion may be visible even when the tooth surface is wet. Challenges. Differential diagnosis. Other conditions such as enamel hypoplasia, fluorosis, and arrested hypermineralized carious lesions can mimic white spot lesions, posing challenges for accurate diagnosis. Determination of etiology. Factors such as the location and surface characteristics of the lesion are crucial for determining its etiology. Visual characteristics for diagnosis. Caries versus hypoplasia, fluorosis, etc. Caries tends to occur at predilection sites, emphasizing the importance of location in diagnosis. Active carious lesions typically appear as matte white, with a rough surface, while arrested lesions tend to be glossy with a smooth surface. Brown spot lesions. Similar diagnostic process. The diagnostic process applied to brown spot lesions is similar to that of white spot lesions. White spot lesion. Challenges in dentine caries detection. Detecting dentine caries, particularly when large cavities are not visibly apparent, presents several challenges. Here are the key issues and difficulties associated with identifying dentine caries. 1. Occlusal surfaces. No visible break. Dentine caries occlusal surfaces may not exhibit a visible break in the enamel surface, making them difficult to detect visually. Shadowing under enamel. Evidence of dentine caries on occlusal surfaces may manifest as shadowing under the enamel, which requires careful observation and interpretation. 2. Approximal lesions. Similar difficulties exist in detecting dentine caries in approximal, interproximal lesions, where cavities may not be visibly apparent from the surface. Limited access. Limited access to approximal surfaces further complicates the detection process, requiring additional diagnostic aids for accurate assessment. 3. Need for diagnostic aids. Visual limitations. Thorough visual examinations alone may not be sufficient to detect all enamel and dentine carious lesions, especially when cavities are small or located in difficult-to-reach areas. Dependency on diagnostic aids. Dependence on diagnostic aids, such as radiographs, bitewing radiographs, caries detection devices, e.g., laser fluorescence, and transillumination techniques, becomes essential for comprehensive caries detection and diagnosis. Detecting recurrent caries is crucial for maintaining optimal oral health and preserving tooth structure. Visual examination and radiographs remain primary methods for identifying these lesions. Here are the key considerations for detecting and managing recurrent caries. Characteristics of recurrent caries. Recurrent caries often appear at the gingival margins of Class II restorations, where plaque accumulation and bacterial activity are common. Over time, the appearance of the restoration may deteriorate, necessitating careful inspection under optimal lighting conditions to detect changes indicative of recurrent caries. Differentiating recurrent lesions. Distinguishing recurrent caries from stained margins on resin-based composite restorations is crucial. Stained margins may not necessarily indicate caries activity. Alternatives to whole restoration replacement, such as polishing or exploratory preparations adjacent to the lesion, may be preferable, especially if the carious lesion is localized. Key point: repair and refurbishing of lesions are preferred over whole restoration replacement whenever possible to preserve tooth structure. Accurate detection and differentiation of recurrent caries are essential for appropriate management. This approach ensures minimal intervention while effectively addressing caries activity, thereby maintaining optimal oral health. Commonly used diagnostic aids. Radiographs play a crucial role in caries diagnosis, offering valuable views for assessing dental health. Here's a breakdown of the different radiographic views, considerations, and frequency of examination. Radiographic views. Bitewings prefer detecting both occlusal dentine and proximal enamel and dentine caries, offering a comprehensive view of the posterior teeth. Orthopantomograms, OPTs, highly accurate for occlusal dentine caries, but less effective for detecting proximal lesions due to superimposition. Bimolars, less useful due to structural overlap, their effectiveness in caries diagnosis. Periapicals, comparable to bitewings in accuracy, but provide less information per film, focusing on individual teeth rather than interproximal areas. Considerations for radiographs. Systematic viewing. Proper illumination and magnification are essential for a systematic review of radiographs, ensuring comprehensive assessment. Age consideration. Bitewing radiographs should be considered for at-risk children aged 4 and above, with the decision based on caries risk assessment and balancing diagnostic benefits with radiation risks. Radiographic examination frequency. Caries-active children, radiographic examinations may be required every 6 months for children with active caries, facilitating early detection and intervention. Controlled caries, children with controlled caries in primary or mixed dentitions may require radiographic examinations every 12 to 18 months, providing regular monitoring without excessive radiation exposure. Bleeding papilla as an indicator. The presence of a bleeding papilla may suggest the presence of an proximal cavity, indicating the need for radiographs to assess the extent of the lesion accurately. Fiber-optic transillumination, FOTI, is a diagnostic technique used in dentistry to identify carious lesions by passing light through the tooth structure. Here's how it works. Procedure. Light source placement. A small, 0.5 mm light source is placed in the embrasure, or contact area of teeth. Transillumination, light is transmitted through the tooth, illuminating its internal structures. Observation, the dentist or dental professional observes the transmitted light and evaluates the appearance of the tooth. Interpretation, dark shadows, carious lesions appear as dark shadows or area-reduced light transmission when observed against the transmitted light. These shadows indicate areas of demineralization or decay within the tooth structure. Location. The location and extent of the dark shadows can provide valuable information about the presence and severity of carious lesions, particularly in areas where cavities may be readily visible. Advantages of FOTI. Non-invasive. FOTI is a non-invasive diagnostic method that does not require the use of radiation or contrast agents, making it safe for patients. Early detection. FOTI can detect carious lesions in their early stages, allowing for prompt intervention and of measures to halt further progression. High sensitivity. FOTI is highly sensitive and can detect lesions that may not be visible on conventional radiographs or visual examination alone, especially in areas such as interproximal surfaces. Limitations. Operator skill. Interpretation of FOTI images requires skill and experience on the part of the dentist or dental professional. Limited depth. FOTI may have limited depth of penetration, making it less effective for detecting lesions in deeper layers of tooth structure. False positives. Some non-caries-related conditions or defects may also appear as dark shadows on FOTI images, leading to potential false positive results. Temporary tooth separation involves the placement of orthodontic elastomeric separators between teeth to create space for various dental procedures. Here's how it works. Procedure. Placement of elastomeric separator. A small, elastic ring, called an elastomeric separator, is placed between two adjacent teeth using specialized dental instruments. Creating space. The elastomeric separator applies gentle pressure on the teeth, gradually creating a small gap or space between them. Allowing time for separation. The patient is instructed to wait for a specified period, usually 3 to 4 days, to allow the elastomeric separator to create sufficient space between the teeth. Removal of separator. After the designated time period, the patient returns to the dental office for the removal of the elastomeric separator. Purpose. Direct access for examination. Temporary tooth separation provides direct access to the interproximal areas of teeth, allowing for thorough examination and treatment, such as placement of dental restorations, removal of caries, or placement of orthodontic appliances. Facilitating procedures. By creating space between the teeth, temporary separation facilitates various dental procedures by improving visibility and access to the treatment. Benefits. Non-invasive, elastomeric separators are minimally invasive and do not require anesthesia or drilling, making them well tolerated by patients. Efficient, temporary tooth separation is a quick and efficient method for creating space between teeth, typically requiring only a few days effective separation. Considerations. Discomfort. Patients may experience mild discomfort or pressure during the initial placement of the elastomeric separators and while waiting for the teeth to separate. Follow-up. Patients need to return to the dental office for the removal of the elastomeric separators and any subsequent dental treatment. A. Radiographic image showing radiolucency on distal of tooth number 15 and mesial of tooth number 16. B. An orthodontic separator was placed and left in place for 3 days. C. Clinical image of the teeth after separation. D. There was no evidence of cavitation on either surface. Laser fluorescence devices. Laser fluorescence devices are innovative tools used in dentistry for the assessment of tooth fluorescence, including the detection of bacterial byproducts associated with carious lesions. Here's an overview of how these devices work, their potential benefits, and considerations for their use. How laser fluorescence devices work. Laser fluorescence devices emit a specific wavelength of light onto the tooth surface. Fluorescent molecules within the tooth structure, including bacterial byproducts present in carious lesions, absorb and re-emit light at a different wavelength. The device measures the fluorescence emitted by the tooth and provides a quantitative assessment of its intensity, which correlates with the presence and severity of caries. Potential benefits. Early detection. Laser fluorescence devices can detect carious lesions in their early stages, often before they are visible on traditional radiographs or clinical examination. Standardized measures. These devices provide standardized, reproducible measures of fluorescence intensity, allowing for consistent diagnostic decisions and monitoring of caries progression over time. Non-invasive. Laser fluorescence assessments are non-invasive and painless, making them well tolerated by patients of all ages. Considerations. False readings. While laser fluorescence devices show promising results, false readings may occur due to factors such as staining, calculus deposits, or soft tissue hyperplasia. Careful consideration and interpretation of results are necessary to minimize the risk of misdiagnosis. Supplemental tool. Laser fluorescence devices should be used as a supplemental tool alongside traditional diagnostic methods, such as visual examination and radiographs, to enhance overall diagnostic accuracy. Clinical judgment. Clinical judgment and experience are essential when interpreting laser fluorescence and integrating them into the diagnostic process. Dentists should consider the patient's dental history, clinical findings, and risk factors for caries when making diagnostic and treatment decisions. Electronic caries meters are valuable tools in dentistry used to aid in the diagnosis of occlusal carious lesions. Here's an overview of how they work, advancements in caries diagnosis, and considerations for their use. Electronic caries meters. Principle. Electronic caries meters measure the decrease in the electrical resistance of carious lesions compared to sound tooth surfaces. Carious lesions have a higher moisture content and lower mineral content, leading to reduced electrical resistance. Accuracy. Clinical trials have demonstrated that electronic caries meters can provide good accuracy in diagnosing carious lesions when used meticulously and in appropriate clinical conditions. Limitations. Despite their effectiveness, electronic caries meters have limitations that must be considered. Readings can be confounded by factors such as hyperplasia, overgrowth of tissue, immature teeth with incomplete mineralization, and especially moisture in the oral cavity. Advancements in caries diagnosis. Enhanced sensitivity. Electronic caries meters offer enhanced sensitivity in detecting carious lesions, particularly in occlusal surfaces where visual inspection alone may be challenging. Objective measurements. These devices provide objective measurements of caries activity, aiding in planning and monitoring of lesion progression over time. Non-invasive. Electronic caries meters are non-invasive and painless, making them well tolerated by patients, including children and individuals with dental anxiety. Considerations for use. Clinical context. Electronic caries meters should be used in conjunction with other diagnostic methods, such as visual inspection and radiographs, to ensure comprehensive assessment and accurate diagnosis. Moisture control. Effective moisture control is essential for obtaining reliable results with electronic caries meters. Saliva or other moisture in the oral cavity can interfere with measurements and lead to inaccurate results. Clinical judgment. Clinical judgment and experience are critical when interpreting readings from electronic caries meters. Dentists should consider the patient's dental history, clinical finding, and risk factors for caries when making diagnostic and treatment decisions. Electronic caries meters for interpreting the readings. Value 1 to 20 indicates sound enamel. This range suggests that the tooth surface is free from caries and is considered healthy. Value 2, 21 to 90 enamel caries. Readings in this range indicate the presence of carious lesions in the enamel layer of the tooth. It suggests early-stage enamel decay that may still be reversible with appropriate preventive measures. Value 3, 91 to 99, signifies early dentin caries. Readings falling within this range indicate the presence of carious lesions that have progressed beyond the enamel and have reached the dentin layer of the tooth. Early intervention is crucial to prevent further decay and potential complications. Value 4, 100. A score of 100 is considered established dentin caries. This indicates advanced decay that reached the dentin layer and may require restorative treatment such as fillings or dental crowns to prevent further progression and restore tooth function. In summary, electronic caries meters are valuable tools for diagnosing occlusal carious lesions, offering enhanced sensitivity and objective measurements of caries activity. While they demonstrated good accuracy in clinical trials, careful consideration of their limitations and appropriate use in the clinical context is necessary to ensure reliable results. When used alongside traditional diagnostic methods and with meticulous attention to moisture control, electronic caries meters can contribute to improved caries diagnosis and treatment outcomes in dental practice.